Professor Necati Ormeci. He is a professor of Ankara University, and he is going to be a president of STC in Turkey in this September. And he's going to talk about the situation of STC in Turkey. Ormeci, please.
Professor Yokosuka, ladies and gentlemen, it's my great honor to be invited for this important meeting. I would like to thank to all the organizing committee. Hepatocellular carcinoma is the third leading cause of cancer death worldwide. Almost 700,000 people die of HCC in every year, and nearly 85% of these cases occur in less developed countries, with China alone accounting for more than 50% of the total cases. In general, the highest rates are found in Asia, West, and Central Africa, the lowest in Europe, Oceania, and North America. US Hispanics and Asians have higher rates than US whites. As you see in this slide, liver cancer almost the fourth leading cause of death. Liver cancer incidence rates show Turkey is the almost lowest, one of the lowest countries about the HCC. So in the males, 3.2%, and females, 1.3%. When we look at the several articles from Turkey, so Professor Akkız, and including me also, we published 1,332 cases, and median age 62, male gender dominant, 85% almost. Liver cirrhosis is the main causes of the cancer, almost 81%. After that, hepatitis B infection, 60%, HCV, 20%, and alcohol, 15%. And when we go to Diyarbakır or Mardin or other southeast cities, then in that areas, delta hepatitis also may cause the liver cancer. So about the first articles, more than 1,332 cases we published, So again, females 18%, males 81%, age 62%, 62 years, sorry, cirrhosis 81%, alcohol 15%, HBS positivity 60%, HCV 20%. So mean tumor diameter almost 5.8 centimeter, and the portal vein thrombosis almost 28%. Those cases has portal vein thrombosis. According to AFP, almost 53% of those cases had less than 100 nanogram per milliliter AFP levels. That means only AFP cannot be trustable for diagnosing of the hepatocellular cancer. So if you compare mean tumor diameter and the platelets, you see platelets levels increasing parallelly with the mean diameter of the tumor. For example, less than 5 centimeters in diameter has 118,000 platelet levels, but when was the increased from 5 centimeter and 10 centimeter in diameter, then platelet levels increasing 145,000. More than 10 centimeter in diameter has more platelet levels. If we compare the nodules and the mean tumor diameters, of course, when the tumor diameter was increased, also nodules is increasing. Also another point, portal vein thrombosis, you see in this slide here. When the diameter was increased, also portal vein thrombosis also increasing. So cirrhosis, the most common cause of liver cancer in Turkey. Interestingly, we found that HDL, high-density lipoprotein, levels higher in portal vein tumor, portal vein thrombosis negative cases, and decreasing if portal vein thrombosis positive, then HDL little bit decreasing and decreasing. So this is an interesting point for us. So I don't want to discuss the other parameters because of the time problem. So already mentioned this one. You see here also portal vein thrombosis and the tumor diameters parallelly increasing each other. I will cancel this one. So, if you talked about the risk factors, male was dominant and the 2 points. Age increasing, 60, 65 years old people has 6 points, and family history of HCC 2 points, alcohol intake 2 points, and serum high ALT levels also higher than the 45, 1 point. So when we see the risk factors, risk scores increasing like this. Another article comparing survival, if tumor number increasing, the prognosis is always worst. And also, when we compare the treatment modalities, survival is better than the others in resection. Follow that radiofrequency ablation, TACE, and no treatment. When we look at the cities in Turkey, especially southeast parts, Diyarbakır, Mardin, and Hakkari, those areas has a lot of hepatitis B patients. And also, almost 12% to 20% of those cases had a Delta infection. But west part of Turkey, İzmir, Istanbul, Antalya, Ankara, 5% hepatitis B we have. But when we compare the HCC cases, south, east, and also Hatay has more hepatitis C patients, but Diyarbakır, Mardin, more hepatitis B patients. Both, they have a HCC. In Turkey, generally, median survival, 14 months to 18 months. If AFP higher than 20 nanogram per milliliter, prognosis is better. When we compare the childhood through classification, child A is better than the others. If we compare the stage 1 to 4, of course, survival of stage 1 is better than the others. When we compare the treatment modalities, surgery is better than the others, according to survival. So this is another important slide. If we diagnose usually, let's say 0.9% in Turkey hepatitis C cases, if we give the usual treatment drugs, then you see total infected cases little bit decreasing year by year. But if we treat those cases with DAAs and we diagnose increasing the diagnostic rates, then HCC cirrhosis, HCC numbers decreasing more quickly in the next future. So because of that, we say that in order to treatment the HCC, it is better to protect HCC before occurring HCC. This is one important message. And the other one, in Turkey, the most important causes of HCC is liver cirrhosis, but mainly hepatitis B. So we have to combat hepatitis B and the C afterwards. Thank you very much for your...
Thank you, Professor Ormeci. Yes, please.
Thank you for interesting presentation. I'm very impressed the data that the diameter of HCC at diagnosis is correlated with the platelet counts in your country. If the platelet count is low, that diameter of HCC at diagnosis is small. That means that in your country, patients with low platelet counts are under surveillance system, but patients with high platelet counts, those people are not under surveillance, even HBs antigen positive. Is that right?
I think a little bit different. I want to give the message. Platelet numbers, of course, can be seen in the cirrhotic patients, Mostly we have a liver cirrhosis, more than 80%. Of course, only platelets cannot be said that this is a prognostic or diagnostic parameters. But we have to be careful. If we diagnose HCC, then we have to check the platelet levels. If platelet levels less, then prognosis looks like better than higher one.
The difference of prognosis who receive surgery and RFA is totally different in your data.
Yes, absolutely.
Well, it seems a little bit curious for us because almost the same prognosis in Japan. And is that because of the treatment entity of the two cases between resection and RFA?
Thank you very much for a nice question. Generally, we give the patients to the surgeon in very early or early diagnostic position. Of course, this depends on the diagnostic time. I mean, if the patient has metastasis or advanced cases, of course, their prognosis is worse compared to surgery, because we gave the patients in early stage or very early stages. Because of that, surgery looks like better than the other modalities. But, sometimes ablative treatments can be done in early cases also. So we have to compare those cases. If the patient had early diagnosis HCC, then we have to compare the surgical one and the ablative treatment one. So then in those cases we can give results. But I think a little less number of those patients, so we cannot compare it. Thank you very much.
Thank you. Although you didn't comment about co-infection of hepatitis delta, is there any difference between the co-infected one or HBV alone?
Thank you very much. So co-infection is less in Turkey, less than, let's say, 3 or 4%. Of course, which infection was dominant, then we cure those infections first. And then I think will not be influenced so much the prognosis of HCC, I think.
Okay, thank you, Professor Ormeci.